Uh, Assalamu alaikum and Bismillah Rahman Rahim. Uh, Hope everything is fine, dear students, with you and your families. Today I'm going to deliver another lecture about retina, and that is about the different kinds of retinal dystrophies. And the most important and the most common retinal dystrophy is retinitis pigmentosa. Typical retinitis, there are two types of retinitis pigmentosas, and we will discuss only the typical retinitis pigmentosa. This is most common hereditary fundus dystrophy and retinal degenerative disease, and it predominantly affects the rod photoreceptors, and later on it involves the cones also. This inheritance is very important because it can be of all inheritance pattern. It can be sporadic, autosomal dominant, autosomal recessive, and X-linked recessive. These are important because these different kinds of inheritance pattern are associated with different severity of the disease. The X-linked recessive pattern is associated with the most severe form of disease and with decreasing order of severity as we approaches the sporadic cases. So X-linked recessive pattern is associated with the severest form of the disease, that is, it may lead to early loss of visual acuity, and sporadic form is associated with the milder form of the disease, and it is associated with delayed loss of visual acuity. What is typical retinitis pigmentosa? There is a classic triad of findings in typical retinitis pigmentosa. There is arteriolar attenuation. There is narrowing of the arterioles, and there is retinal bone spicule pigmentation. This is, like the bone spicules, there is pigmentary changes here. It's not diffuse. This is like spikes. It's like a bone spicules, like a bones in the spongy bone spicules, shape like the spongy bone. This type of pigmentary changes, and there is disc pallor. So these three class features are classic triad of retinitis pigmentosa. To diagnose retinitis pigmentosa, you need to see arteriolar attenuation, retinal bone spicule pigmentation, and waxy disc pallor. Presentation is with nyctalopia. Nyctalopia means inability to see at night and difficulty in dark adaptations. Dark adaptation means that when you go from the light to a dark area, the time taken by your visual system, visual pathway to adapt to that dark light is known as dark adaptations. So the patient will come to you with the complaint of inability to see at night, and there is prolonged dark adaptations. And later on, the patient also develops peripheral visual disturbance, as we know that the rods are more concentrated on the retinal periphery. So there is disturbance of the peripheral retinal visual acuity also. On examination, the visual acuity is variable. It may be normal or it may be severely affected. As I told you earlier, like in cases of sporadic cases which are inherited in a sporadic way or autosomal dominant way of inheritance, they may have normal visual acuity for longer period of time, because the involvement of the macula is delayed. This is the macula. See, this area is affected. This area is affected. The macula may be spared, although here there is one of the complication of associated with retinitis pigmentosa is there, that is known as cystoid macular edema. So the visual acuity may be variable depending upon the mode of inheritance. There is intraretinal perivascular pigmentary changes. See this one? These are the vessels, and surrounding these vessels, these are the pigmentary changes. These are the pigmentary changes, and these pigmentary changes increases with the passage of the time. It increases. Ultimately, this is the final picture, and there is atrophy of the RPE. The retinal pigment epithelium loses the its pigmentation, and because of atrophy of the RPE, we can see the large choroidal vessels. Okay, so RPE atrophy and gradual increase in the pigmentary changes. So here we can see actually the pigmentary changes are increased, and we can see the large choroidal vessels. These are the large choroidal vessels that we can see in advanced cases or advanced disease. I have already discussed this one, unmasking of the large choroidal vessels due to RP atrophy. Okay, and there is waxy gliotic pallor of the optic disc. Optic disc become pale, and there is macular atrophy. There can be macular atrophy, epiretinal membrane formation, or cystoid macular edema. Here, this one. See, this is cystoid macular edema. This is the area. There can be atrophy also. There can be cystoid macular edema, and there can be epiretinal membrane formation. So the patients actually lose their central vision because of these three problems. The females, X-linked recessive females, they are actually carrier. They do not show the full-blown picture. Here you see the a tapetal reflex, a glistening reflex in females who are X-linked recessive. You do not see the full-blown picture here. You see a glistening tapetal reflex in the macula, and you may see some pigmentary changes at the periphery. So these patients, these females, are carrier, and they can transmit the disease in the next generations, but they do not show the full-blown pictures. There are different ocular complications that can occur with retinitis pigmentosa, or in patients who have got retinitis pigmentosa, that is posterior subcapsular cataract. The incidence of open angle glaucoma is increased in patients who have got retinitis pigmentosa. There is increased incidence of myopia. There is increased chances of keratoconus, and the patients have got early vitreous syneresis, and that leads to the posterior vitreous detachment. And these patients sometimes present with intermediate uveitis also. And these patients can also have optic disc drusions. So there is crowding of the optic disc, and this crowding of the optic disc can lead to the central retinal vein occlusions. And sometimes these drusions are also associated with choroidal neovascular membranes, or the incidence of choroidal neovascular membrane is increased in patients of retinitis pigmentosa who have got this optic disc drusions. There are different investigations which we need to do to diagnose a patient of subclinical disease, or patients who have got subclinical disease. I mean the patient who are coming with the complaints of nyctalopia or prolonged dark adaptations, but they do not have the clinical features visible on the fundi, or we need to confirm the diagnosis of retinitis pigmentosa. We have to do different investigations. The first one is ERG, electroretinography, that shows reduced scotopic, rod, and combined wavelengths. So this is actually the 5 readings that we do in ERG. So here actually the scotopic rod and combined waves, they are reduced in their amplitudes, and ultimately these lines become flat, okay, because this ERG is extinguished in long-standing cases of retinitis pigmentosa. There is another investigations that is known as electrooculography, and that is also subnormal with absence of light peak. And as I told you earlier, the dark adaptation is prolonged even in early cases. And on perimetry, that is visual field examination, that will show annular scotoma. See this one. Now this one is the pigmentary changes involving all of the retina. So this will give rise to annular scotoma and sparing the central visual acuity. Okay, so patient will have annular scotoma because of this mid-peripheral increased retinal pigmentary changes, and because of the sparing the macula, the patient has got tunnel vision, and this will lead to a scotoma. Patient cannot see in this area of the visual field. How can we treat a patient of retinitis pigmentosa? Honestly, still there is no treatment which can improve the symptoms of the patients or which can ameliorate this disease. There is no such treatment available up till now, but there are certain treatment measures that we can take in cases of retinitis pigmentosa. That is that keep the regular follow-up in these patients, because we can diagnose different ocular complications that we have discussed in the previous slides, that we can see the cataract. If this is there, we can do cataract extraction, and if the patient is having glaucoma, we can treat the glaucoma also. And if the patient is having cystoid macular edema or he is having epimacular membrane formations, we can treat these two conditions. So we cannot actually treat the disease itself, but we can treat the associated complications. This gene therapy and retinal prosthesis, this can be practiced. This is being practiced in the modern world, and the patients they improve their visual acuity with this retinal prosthesis. And as I told you earlier, with the regular follow-up, if you see that the patient is having cataract, we can do the cataract surgery. We can prescribe the patient low vision aids, and this one actually we have to ask the patient to stop smoking, because this is, I think, associated with worsening of the disease. Another option is to prescribe the patients this nanometer controlled glasses to block different wavelengths. So you give these nanometer controlled glasses to see the patient that can block different wavelengths in light, and you can prescribe the glasses to the patients which can block certain wavelengths at night, so the patient can have a little bit of clear visual acuity. High doses of vitamin A supplementations, this is also arguable, and this needs to be given with a caution, because this can lead to different kind of malignancies. This can be a cause of different kind of malignancies. Treat the cystoid macular edema, we have discussed it earlier. This is associated with cystoid macular edema and epiretinal membrane formations. So we can treat this one with acetazolamide. The cystoid macular edema associated with retinitis pigmentosa is is a treatable conditions, and the treatment of choice is oral acetazolamide. And because the retinal condition is already compromised, So we need to avoid the drugs which cause retinal toxicity. So avoid retinotoxic medications. There are a lot more medications that can cause retinal toxicity. So you need to read the list of that drugs also. The most common is this chloroquine, you know, and this cause a very similar picture to the retinitis pigmentosa. Uh, Actually, this retinitis pigmentosa in our native language is known as andhrata. So the patient will sometimes come to you and say that he or she is suffering from andhrata. So the native word for this retinitis pigmentosa is andhrata. See a lot more patients, but unluckily we do not have any proper treatment for these patients. But by having a regular follow-up of these patients, we can, you know, prolong the visual status of the patients by managing these cataract, glaucoma, and this cystoid macular edema. Thank you so much.